when you come visit me there. Just quickly would also like to thank you all for coming and listening today, and I look forward to engaging with you and your questions. Special shout out to my family sitting here. Thank you for coming and supporting me. And also one of my former students is here as well, which is really very cool. And hopefully there's a few of you on Zoom as well. Okay, so I'll just get started. I'm excited to share with you what we've been doing for 6 years in Rwanda on our research on the family planning program there. But before I get into Rwanda, I wanted to talk a little bit about me and my background. So I started with a bachelor's in science and biochemistry from Cal Poly in San Luis Obispo. And after graduation, I ended up in Jamaica as a Peace Corps volunteer for 2 years. And while there, I discovered my interest in public health. So I applied for graduate programs as a Peace Corps volunteer. I ended up going to Johns Hopkins Bloomberg School of Public Health, where I first earned my master's in health science, which is very similar to an MPH. But at that time, the MPH was designed more for mid-career professionals. So they had other master's programs for people who were younger and not yet in careers. The program allowed us to have an internship and in the second year of the program. And I split my time. I started at the US Census Bureau and spent about 3 months there as an intern. And then I had the great fortune of going to Ghana in West Africa for the second half of my internship. It was my first time going to Africa, my first time in Sub-Saharan Africa, my first time in West Africa, and it was a life-changing experience. It was so impactful that I applied to do a PhD program in the same department, and I proposed a dissertation to return to Ghana and do research on abortion. At the time of my master's, abortion was the leading cause of maternal death in that nation. And so I felt a strong desire to contribute to the literature on that topic. So now I'm going to, I forgot a slide. As mentioned in my bio, I'm a professor at Fairhaven College at Western Washington University now, and I've been there for about 13 years. And, oh shoot, this came before that, my bad. Before I got to Western, my first research position was at a place called the Center for Communication Programs. And at this center, I was able to work on 2 big projects. One was called the Go Girls Initiative. And the focus of this program was on reducing adolescent girls' vulnerability to HIV. At the time, and I think it might still be true, adolescent girls were 3 to 5 times more likely to be infected with HIV than their adolescent male peers. The project was in Botswana, Malawi, and Mozambique. And it was a real pleasure to work on this project. I also was able to work on the Nigerian Urban Reproductive Health Initiative, which was focused on increasing contraceptive access and use in urban areas of Nigeria. I also got to work on a few other projects at that time, one of which was about malaria and pregnancy in Zambia, which we chatted about earlier today. Okay, so now why Rwanda? So my interest in Rwanda was piqued when I went to a conference and I was in a malaria session, and someone else was presenting on how malaria incidents had reduced dramatically in Rwanda. And it was such a significant reduction that I was in disbelief that that could actually happen. But it piqued my curiosity to look into family planning in the same nation to see if something positive around family planning had occurred around the same time period, and it had. So contraceptive use increased from 17% to 53% from 2005 to 2015. And then later, it increased to 64% in 2020. So I was really interested in understanding how Rwanda went from a fairly low contraceptive prevalence rate to a really pretty good contraceptive prevalence rate in such a short amount of time. My colleague Seth Feinberg, whose picture is up there on the top right, asked me if I'd be interested in doing a grant with him on Rwanda. And I said, absolutely, as long as we can study family planning. And he was on board for that. So we submitted a grant to the National Science Foundation under a funding stream called the Research Experience for Undergraduates. And this funding stream is specifically designed to increase undergraduates' exposure to research, particularly undergraduates who are underrepresented in the sciences and who go to colleges or universities that don't have a strong research portfolio. We were awarded the grant in 2016, and we had 3 years of funding. And we went to Rwanda 3 times between 2017 and 2018. At the end of 2018, we wanted to try again. So we submitted another grant. We actually returned in July in 2018, and we submitted our second grant in August of 2018. And we were funded in 2019 a second time. But as you know, COVID happened. So we had plans to go to Rwanda in 2020, and those we had to change, and we had a 2-year hiatus. In 2021, we did do a virtual cohort. We didn't do anything with Rwanda. With that cohort, we used existing projects with our students for that 1 year. And then we were able to return to Rwanda in 2022. And we just went for our last time on the second grant in 2024. I just wanted to put up the social ecological model as a public health researcher. This was a big part of my graduate education, and it guides my view of the world and my research agenda. Always thinking about how we as individuals are not autonomous in our world. We're largely impacted by those systems within which we live. This is a picture of our first cohort. We went in the summer of 2017. And it wasn't my first time going to Rwanda. I had limited connections. I was working hard to make more connections before going. But we got there and we understood that we would just be starting from the ground. We also partnered with the local university. So we added 5 Rwandan undergraduate students to our study team. And then we just started talking to people as much as we could, making connections, using those connections to make more connections. And our study design was to do key informant interviews of family planning experts in Kigali, Rwanda, the capital of the nation. We ended up with 13 key informant interviews with these family planning experts across a broad range of expertise. And our interview asked about the positives, remaining challenges, future outlook, as well as potential for translation of successful elements. What we found is that the government's will, leadership, and management of the program was the biggest positive, and all of the other positives came from that initial main positive. Some challenges remained in terms of rural access, adolescent access to and use of contraception, opposition from religious institutions, and inadequate human resources and funding. When asked about the future, our study respondents were positive and said that they recognized that there was room to grow, but they were hopeful that the country would continue in those efforts. One participant said, "I call it a journey. It is not something you achieve and finish and go, because human life continues, people still continue." And in terms of translation, our key informants said that sure, it might work, but context really matters. So it's difficult to say whether what works for us might work in another setting. This is the publication we had from that first cohort on that material. For our second cohort in winter of 2018, we went back with a focus on service providers. We picked 2 different districts with the highest and lowest CPR based on the DHS data. And we did 8 focus group discussions, which were split evenly into those 2 districts. 2 with family planning nurses and 2 with community health workers. Through our key informant interviews in the first cohort, we learned about the importance of community health workers. So we are eager to include them. in our study. After we held these focus group discussions, we translated and transcribed into English. We used thematic coding analysis. We coded in Atlas TI, and we analyzed with ENCODE using spreadsheets in Excel. So we could also make tallies of the sub-themes. Our third cohort in the summer of 2018 did a similar study, but this time we focused on contraceptive users. So we went back to the same 2 districts, and we did a total of 32 in-depth interviews with contraceptive users, split evenly by the 2 districts. We were pleased to find that the results were very complementary. So we ended up, from this point forward, doing the analyses together from the focus group discussions and the in-depth interviews. These data were very rich, so we had many publications from this. I'm going to share with you the publications and the main findings. So provider-client relationships came up as a really important factor. And particularly from the providers talked about how they worked hard to have strong relationships with their clients. They wanted to understand, learn from, and support clients in initiating and sustaining contraceptive use. And all of this despite having struggles with inadequate staffing, resources, and training. And one family planning provider said, "It's inside you to give every client the service she wants." We also found some findings around financial security. So we asked contraceptive users, what's your motivation for using contraception? And a common response was having financial security in order to provide for children. As this respondent says, we have to first think what we're going to feed our children before we have them. So respondents felt that family planning was critical for providing a better life for their children. And the main avenue for doing that was giving mothers time and independence from childcare to go and work and make money to provide for their existing children. I recognize it as an opportunity for generational upward mobility. And there was also a recognition that by doing so, they were positively contributing not only to their children and their families, but their society as well. There was also findings around couple collaborative contraceptive use, a bit of a mouthful. And this paper, we found that women and providers both prefer couple collaboration in contraceptive use. The burden is often placed still on the woman to initiate the conversations, seek out the information, and share that information back. However, after the information is sought and brought back, the decision-making about the use can be done very collaboratively and motivated by financial reasons by both parties. When contraceptive use is collaborative, there are many benefits ranging from marital harmony to supporting sustained use. Despite the fact that most people were collaborative with their decision-making and supportive of use, some male partners refused to use male methods, and some men were not supportive of contraceptive use. Both providers and women noted in those scenarios, covert use could be not the best option, but an option in those scenarios. We also found evidence of demand generation for family planning. The demand generation was occurring at the government level through very vocal support of family planning, mass media messaging, and also community meetings. In Rwanda, there's some unique community meetings that I haven't seen in other nations that I'm familiar with. Every month, there's one day in the month, I think it's on a Saturday, that it's called Umuganda, and the entire nation, nobody does anything but does service in their community, and the service projects are communal. So the community does the service project together, and after the service project's done, so they might do that for 2 to 3 hours, there's a time of sharing. And the sharing is, the messaging comes from the government, so every community is talking about the same topics. And sometimes those topics are about family planning. There are other community groups that get together, like there's a women's group that gets together monthly, where women in the community come together and support each other around through discussion topics that are relevant to their current lives. So we found that these multiple layers of messaging were supporting interpersonal dialogue among people through observation of seeing other people use family planning, but also through conversation with peers and networks about family planning. Despite these efforts, rumors and misinformation continue to be a barrier to use, just like in most settings. But we did see that people were nodding to the fact that family planning used to be a taboo subject in this culture and now has become one that's normative between married couples. Another area of finding we have is coordinated and integrated family planning service delivery. So I had mentioned earlier that in Rwanda, they use community health workers to help deliver family planning services. And we found that the family planning nurses and the community health workers were working in very complementary ways. So the community health workers are voted on by their peers. So each community has 3 community health workers, and the community votes on who those people should be. And those people then are trained and tasked with helping their community members in healthy ways. And one of the areas is family planning. And the community health workers are connected to the family planning nurses that are in the health clinic in their area. And they share information about their clients and they pass clients back and forth. For example, community health workers cannot initiate a hormonal method with a person, but they can start the conversation with an individual, learn what they're interested in. And if it's a hormonal method, then they take that person to the clinic where they can meet with a family planning nurse. And then the family planning nurse might initiate a method with that person, but once they've been using it, they might pass them back to the community health worker to continue the resupply of that method for that individual. As this participant said, it is so easy to get the product that I need. It's so easy. There are family planning providers close to home, talking about the community health workers. Another finding was the integration of family planning into other maternal and health services. So family planning showed up in the family planning clinics, but that was not the only place people went to learn about family planning. So there were mentions of family planning services, particularly in prenatal care. So among pregnant women who were coming in for pregnant services, family planning was a part of the health services that they received. It was also part of postpartum care, so right after delivery, and then also part of newborn care and child care. As this participant describes, I was going to the health center getting some tests for my first child when the nurses reminded us that the family planning program was also there. Another area of finding is discontinuation prevention. So discontinuation is a common problem for family planning programs. About half of users discontinue a method within a year of use, starting use. So it's very common for people to discontinue contraceptive methods. And perhaps any of us in this room can relate to that as well. So in Rwanda, providers prepared new users for potential side effects. So they were really upfront about what are the common side effects with these methods before new users started with a method, so they hopefully wouldn't be surprised by side effects when they showed up. They provided options for switching, and they gave reminders about resupply. Because one way to reduce your side effects is to be consistently resupplying and redoing your contraceptive methods on time. So the hormones remain at a consistent level in your system as opposed to fluctuating. If someone did have side effects, they were encouraged to come back to the clinic for counseling and medicine to address those side effects. Users also talked about how they were aware side effects vary by individual. So one person's experience may not be the same for another. They were very comfortable with switching methods, and some of our participants switched a lot of methods. They supported their peers. They talked about how they talked with their peers when they were struggling to give them motivation and support to continue. And some described sustaining use despite really severe side effects, as this participant explains. I was bleeding so much and I lost weight and I was about to faint. The doctor told me to go home and continue using the withdrawal method. That is when I refused to go home and I insisted that they give me the injectable again. The last paper within these two cohorts was about adolescent contraceptive use. And as you can see from the leading quote here, some foreshadowing. This provider says, "She is courageous because she does not care what people think about her." So we found that the main barrier for adolescent contraceptive access and use is premarital stigma regarding premarital sex, which is pretty common, I think, in many cultures. And providers could act as barriers. So providers talked about how they emphasize secondary abstinence. So they talked about how they would befriend these clients and then act like a mother figure and then encourage them to stop having sex and instead abstain. They offered a limited selection, so they only offered a few short-term methods to adolescents. And they also emphasized risks with sex and with contraceptive methods. Despite these barriers, providers could be supportive. They were very concerned about adolescents' privacy, their confidentiality of what they shared, and that they got their services really fast. So they talked about if they saw an adolescent, they would bring them in quickly, take them to a very private space, counsel them quickly, provide them what they need, and get them going. They really didn't want adolescents interacting with the married women who were also there for the same services. Interestingly, female community members were more supportive of adolescent access and use of contraception. And I think this came because community members were more intimate with the communal repercussions of adolescent pregnancy. So they felt in their community how adolescent pregnancy could break down families and communities in certain ways. We did ask contraceptive users about how they talk with their teens about sex. Some were comfortable doing so, most were not. Most found that to be a very difficult thing to do. So we got our second grant, and we had some delays with COVID, as mentioned, and then we started going back to Rwanda in 2022. And when we were in Rwanda for our first grant, we had been exploring other ways we could engage with the family planning program there, should we get subsequent funding. And we visited health clinics, and we were surprised to see the detailed notes every family planning client would have. So they had a card by the government, and they would fill out the card for each family planning client who would come in the clinic. And then they would keep those cards in the clinic in this, it's a little bit hard to see it up in the right corner there, but they have these wooden boxes made, and each slot would be a different, smaller geographic cell within that area of that health clinic. So when someone came back for services, they would ask them where they came from, get those files from that place, and then find their file within that small section. So for me as a researcher, I saw the possibility of data sitting in these clinics, and the data are not being used beyond the clinic. The clinics would summarize mostly they would summarize the number of people coming and what method they took and submit that back to the government. But all of the other information on those forms was not being used in any other way. So we designed a study to go into health clinics and extract the data from these forms. And we focused only on IUD and implant users when going back to the clinic. We extracted data on demographics, fertility, desired contraceptive method, selected contraceptive method, and all follow-up visits. We only included clinics that served 100 clients or more a month. We rank ordered them by client volume, and then we took a subset of those, which differed by the two districts, because Namasheke is a bit bigger of a district than Musanze. We ended up entering 21,456 records over 2 summers. So in 2022, we went to Musanze, the district with the highest contraceptive prevalence rate, and in 23 we were in Namashiki doing the same, but in a different district. It was very common for the forms to have missing data on them. Almost half of the forms had at least one missing variable. And don't think it wasn't systematic. It was more so, I think, just fatigue with data and filling out those forms all day long, which collected a lot of information on each person. So we looked into the missingness and found that it was not strongly correlated with other measured variables. So we treated the missingness as random, and we found it was a good candidate for multiple imputation. We used the ICE method in Stata to create 20 imputed data sets with an augmented regression model to help reduce bias resulting from perfect prediction. We combined the results from these data sets using Stata's MI suite of commands to summarize results by applying Rubin's rule. And then finally, we fit multi-level regression models with random intercepts and cluster robust standard errors for the facility attended. That way we could examine the relationships between the receipt of desired method and the variables within the facility. We expected women to get what they wanted, but not at this level. So really, really pleased to see that 95 to 97% of women received the method that they wanted, which is a really big deal because in family planning literature, if a woman gets what she wants, she's much more likely to sustain use and not discontinue that method. So getting the method that you want means that you're more likely to continue using the method successfully. So a really, really high level of people getting their desired method. We did some analysis to see that small percentage of people who didn't get their method, what were some of those characteristics? And across both districts, we found that postpartum women were a little less likely to get their desired, were less likely to get their desired method. And in Musanze, there were a few more variables, having more children, using for spacing, and having an abortion history. But most of that variation was explained by facility, which means that there's probably a little bit of provider bias happening in specific facilities, more so than others in terms of not meeting client demand. Another finding is that most people, when they use contraception, they start with something a little bit simpler, like a condom or the pill. And then they might progress to more invasive methods with time. We were shocked in Rwanda to see that so many women were using implant as their first method. So their first contraceptive method was a long-term method. And so we did analysis to look at the difference between implant users who were using implant for the first time and implant users who were people who switched to implant after using other methods. And we found that women who were choosing to use implant as their first method were more likely to be younger, moderately educated, and be on their first child or have fewer children. And we found less facility variation with this outcome. So we haven't finished the analysis on this third variable yet, but I'm really excited about this one too, because something that really surprised us when we were entering the data was seeing that women were coming back on the exact day they were told to come back. And this would be like, every follow-up visit would be at least 3 months from that initial visit or more. And people were coming back on the day. And even when that day was a year later, they were coming on that day. So this analysis is looking at that timeliness with follow-up. But we also noticed that that was the majority of people coming back on time. But sometimes people would start to falter. They might come a day late, and then the next time they come 2 days later. And when people started to falter, then they quickly switched to something that was more long-term, like an implant. So this analysis is going to look at that timeliness, and then when that timeliness starts to falter, how quickly the switching happens. So this is the last cohort that went to Rwanda this past summer. And with this last visit we wanted to ask some more why questions. So when we extracted those data from the family planning client forms, As you probably happens to you all the time in research, for us, it raised more questions than answers. And so we were eager to use some qualitative work to answer some of those why questions that came up from those forums. So we really focused in on implant users, and we wanted to, again, include family planning nurses, and we also did in-depth interviews with implant users. We didn't include community health workers this time because community health workers are not involved very much with implant users, given that it's a more invasive method. So we're still working on these findings, but we have some to share with you. And one area of finding is around male involvement. We found that men were reported as being mostly supportive of contraceptive use, and male motivation for contraceptive use fell into many categories: birth spacing desires, better finances, increased intimacy, less stress, and having a more caring home life. At times, in a more rare scenario, men were not supportive, and when they weren't supportive, the women might go towards covert use. And providers and women both were supportive of women doing what was right for them. But if men were to find out about covert use, sometimes that would result in forced removals of implants. So one participant said, contraceptive use can also increase the love between husband and wife. And another participant said, when the wife joins the family planning program, he feels happy in doing his action. And action here means sex, having sex. So one of the big themes that came out of this was that family planning lets people feel more free to be intimate in their marriages, which is something that I think a lot of people can relate to too. Also, implant is the best method came up a lot in our work. And people in this context are using family planning to space their births, and they want to be able to breastfeed as soon as they give birth. And implant is the most popular implant in Rwanda gives you protection for 3 years, which is a great birth spacing duration. And it is compatible with breastfeeding. It's also very effective in pregnancy prevention. And finally, another big benefit of implant is that you don't have to take time to go back to the clinic very often. And people really appreciate that, because what they really want to be doing with their time is working, instead of taking time out to travel to the health clinic, wait in lines to see the provider, which takes away from their ability to make money for their family. We also learned about implant removal, and a little background on implant removal for you all from the literature is that there's a lot of concern that people are getting the implant easily, but when it's time for them to get the implant out, there are a lot of barriers to getting the implant removed. And so we were surprised to see that here in Rwanda, that removal is reported as being on demand, wherever and whenever requested, and going fairly quickly, between 1 and 12 minutes as reported by the providers. And the participant implant user says, anywhere you go, you can remove it. And we also learned a lot about implant reinsertion. So the implant is so popular in Rwanda right now, and people just want to keep using it consecutively. And it's very common for someone to use the implant for 3 years, come back on the day it expires, and ask for another one if they're not ready to have a child at that time. And so providers talked about how this was common, and they would insert the implant in the same arm, but do it in a different direction than the first one, to avoid multiple wounds in the body, and also hopefully reduce the pain for the user. This provider says, normally they come for removal and they go back with a new implant inserted. So in summary, Rwanda's family planning program has many positives, starting with strong governmental support, well-planned infrastructure and organization, and they recognize the user's choices and decisions are paramount, and service providers respond immediately to those requests, which is very, very, very important. But family planning has a long history of not doing that. And so it's a great example of how it can be done and how it can lead to success. Users are also able to access services wherever they live, even in rural areas. But challenges do remain, particularly around adolescent access to and use of contraception. And this is beyond the service delivery environment. It really will require a cultural shift in norms, which I think is actually true for our culture as well. Hopefully we'll all get there too. There's also the issue with staffing shortages and support. And I do think that there might be some bias towards pushing long-term methods on users because providers are feeling the squeeze of time. And it's a lot easier to provide family planning to someone who never comes back for 3 years than someone who's going to be at your door every 3 months. Yeah. So now I want to return it back to me a little bit. I'm really excited to be here with you all and share this with you all. And I wanted to put it out there that I'm interested in doing research with new colleagues, faculty, and graduate students alike, particularly in the areas of abortion and contraceptive use in sub-Saharan Africa and or Washington State. And generally any reproductive justice topic is my jam. And so I look forward to your questions and conversations about this material. Welcome. Okay. Yes.
I was wondering if you could talk a little bit more about methods that wasn't, for example, also users, there are a lot of users. And then secondly, could you talk a little bit about maybe any of the discrepancies between provider response and patient response? It sounds like there was a little bit there.
Yes. Yes, good question. So we included IUD almost logistically easier because the clinics organize the files also by method, and they put implant and IUD together. So they were going to be mixed in. And IUD is pretty rare. I can't remember the exact, might be like 2% of use. It's really pretty low, but there is some. So we do have data on IUD users. And I'm glad that we have it, but again, it's much smaller than implant uses by far the main focus. Did you want to know about other methods too? Or?
Yeah.
Okay, like why not the other ones too?
Yeah, and if you did include them, what the plan is.
Okay. So interestingly, the short-term methods were hard to include because we were entering all the follow-up data, and they were coming so often that it took way longer to enter those data than it did to implants. But we did get those data for people who switched to implant because we would have all of their use prior to implant. So we do have some on condom pills, primarily injectables would be the main second option in Rwanda right now. But I don't have much for you on those specifics within that because implant really is the main story. But with our third paper about timely follow-up, pills and injectables are going to be a big part of that story because most of that timely follow-up is for pills and injectables because implant users actually like disappear. Like they just go. They don't come back because they don't actually need to come back. And a lot of them are really glad that they don't have to come back, so they don't make an effort. And then you have, discrepancy between provider and client. Not really, not too much, yeah. But thank you for bringing that up because we are still in the analysis of last summer's qualitative data, and we have provider and client. So we definitely look at differences by tally. So we tally like when people contribute to a theme or a sub-theme, and then we look at it by any demographic that we sampled on, which is really just districts and if you're a provider or a user. So we can definitely look at the numbers to help us signal where we should go back and look again at those themes. And we definitely do. Thank you. Yeah.
I had the privilege of getting to learn more about this last night too, so I've been thinking about it a bit, and I'm curious if maybe you can put the your study and actually even like your research agenda within the context of Rwanda's history, and what does it mean to study reproduction in a post-genocide context?
Yeah, it's a really good question. And I think that's part of what makes Rwanda's story so unique too, is that the genocide in 1994, the focus really of the people of the nation was on life, not on prevention of life. And so typically when you look at family planning in a nation, it never goes down. Like contraceptive use may stay steady, it may go up, but it doesn't go down. In Rwanda, it went down. So from before genocide, after genocide, contraceptive use takes a major spike. And it starts to come back up. But it didn't really take off until the government was like, we really need to do this. And the government had to convince the people, because the people were like, are you crazy? Like, we need to rebuild. We don't need to think about being careful about our family size. But they put out the messaging, and they were really consistent with the messaging about how important this was. And the culture is very much compliant with the leadership, like looking to leadership for leadership and then wanting to follow in that guidance. So it is interesting because it comes from, it's not an outside influence necessarily that, like came in and was like giving a lot of pressure. There was signaling from outside actors, but it really came from the internal government system as a message of like, this is what we're gonna do now. And it definitely didn't take off right away, but it did after some time. And something also really interesting about Rwanda is, again, because of the genocide, the government realized that if they did not embrace women in leadership, they would not have enough leaders. And so one thing they did as they were establishing their new government is they made, I think it would be a law that said our parliament has to be at least 50% women. And at the time, that was unheard of. This is quite a while ago. And there was a lot of like questioning if that was even possible to go from a situation of not having many women at all in your government to having representation that high. And in that first election cycle, 64% of the parliament was female. So they never had to implement the law. They never had to say like, okay, we didn't make it, we gotta make sure we do it. And they haven't since. And they lead the world in representation of women in government still. And I think there might be a connection there too with family planning and reproductive health, with having such a strong representation of women in government. Thank you for the question. I'm forgetting to say the questions. I'll do that. That's fine. I'm sorry about that. Yeah.
I had a question about the RU students. How did you talk more about how you use them and maybe how it changed over the course of the project?
Yeah.
Yeah, just great.
The undergraduate students? Yeah. So it was a bit of, oh, thank you. I'll say it again. How were the undergraduate students involved in the research is the question. It's kind of a challenge because we wanted to do this research, but we also wanted to make it so undergraduates could be a part of it. And then we also had the language barrier. So we were constantly trying to manage, thinking about how methods that we could use, that we wanted to use, questions that we wanted to answer, but we're also places where we could bring in undergraduates to be a part of that. And so the qualitative worked really well because they weren't able to collect the data, but they were involved as soon as the data were collected in the transcription process. So we did the translation and transcription process together. So we would pair the Rwandan students who collected the data with our US students, and we would work out making that transcript. And So they could be involved from that part on all the way through. I thought they'd be more involved when we first designed this in research and study design. But as you know, it takes so long to get everything approved. And we only get 8 weeks with the students that we quickly realized like we're gonna have the studies ready. And then they're gonna be more involved in the analysis side. We partially picked the data extraction study because it was something that students could do without, like you didn't have to have the language in order to. But the students quickly complained about, it was really intense work, you know. I don't know if any of you have extracted data for 8 hours a day, but it's exhausting. So I think they enjoyed being a part of it, but they were also intimidated by the analysis part of it too. And we got better at each step of the way. We got better at engaging them and teaching them these pieces, but it was a learning curve for us as well. And I think another learning piece for us was that undergraduates don't necessarily want to be a part of your program once it's over. And research, as you all know, doesn't end in 8 weeks. So that was also hard for us as we were like, wait, we're still doing it. And everyone's like, bye. But what has worked well is 2 students have been lead authors on our papers so far. And one used it for her master's thesis, which was great. The demand generation was led by a master's student. And then another student, she was just crazy motivated to do it. But we've had students come back to us like after years and say, hey, is there anything we can do? And the answer is always yes. Yeah, great question. Yes. Yeah, thank you.
I wanted to ask about finding related to women not having your choice and the time was hard. Yeah. What is the postpartum window there? And you start into the patterns that like a particular type of contraceptive that you're seeking, and you know, what it maybe women.
Yeah. Okay, the question is about the postpartum finding in terms of not getting the method that you wanted. So quickly, just a reminder, most postpartum women are getting the method that they want. The time window is really interesting. So the government, I'm not sure what year, but there was a very strong push from the government to do postpartum family planning immediately after labor. So most women are going to facilities to give birth. They give birth, and within hours, there's a nurse talking to them about family. And for some of them, it's like, are you kidding me? And for some of them, they're like, please now. So there's a mixed response with that. But if someone is like, they'll come back later. So you can't really leave the clinic without talking to someone about family planning after you give birth. And you can say no, but there's a lot of encouragement to choose something. I did look at it by method, and it's kind of, it'd be fun to talk with you more about this because it feels like there aren't that many methods. But when I started looking at by method, I was like, this is getting kind of weird fast. And part of that is it's small groups that didn't get what they want, but it's hard to find patterns of not getting. I couldn't find, but I would love to share with others and see if you have ideas about how to do that. Yeah. Yeah, thanks. Yeah.
Just to ask about the main like geographic heterogeneity findings in store. Yeah, or I don't know if there's anything beyond that you can extrapolate based on your experience over there.
Yeah.
But what do you think about how different places, people in different places respond?
Good. Yeah, great. Okay, so the question is about like, are there geographic differences in how people respond? And the country is pretty small and is very densely populated. And so we do notice differences as we're moving around, but not many. But for us, we picked Musanze, which is in the northwest-ish And then Namashiki, which is in the east, bordering Lake Kivu, which DRC is just on the other side. And there were some big differences between those two that came out. And the biggest one was that for the more conservative district on the west coast, or by Lake Kivu, there were a lot more religious groups that were evangelical style, and they were really loud about them. You're not a member of this church if you use family planning. And in our last summer, we had some people, we don't have a lot, so it's not enough to make a paper out of it, but it was really compelling quotes where people were like, I hide my family planning use because I don't want my church to know. So there's more religious evangelicalism in that district, which I think is one of the bigger impacts on those differences with family planning use. But another one is that district is huge. It doesn't have as much money. It's poorer and it's more spaced out. So it's harder for people to get to places. They have to travel a bit further. And so those can be barriers to getting family planning. But like strong reactions to the government, we didn't see that variation in that. Yeah. Thanks for the question. Oh, yes. Yeah, thank you for that. The question is about whether there's opposing views and in the government, within the government. You know, I don't really have experience with that, but the one place I do notice it is around adolescence. So the government has put out this very fabulous adolescent and reproductive health plan to be very open and do all these things. So it's there on paper, but when you talk to government officials, they're like, it's very inappropriate to talk to teens about sex. So there's a disconnect between some of what they've put out and people's beliefs. And I think the people who authored the policy are people who are like, this is, we can do this, but there's not a lot of other support. People are really uncomfortable with teens having sex. The idea of teens having sex before marriage is like so wrong. That the idea that a teen needs contraceptive is almost laughable because it's like, that means they'd have sex, and that's so crazy. Yeah. Yeah, no question.
In talking about Rwanda, when you selected that for your study, was it because was one of the factors a higher women's leadership component, or did you discover that later?
So did I want to go to Rwanda because of the women in government in Rwanda? I was primarily because of the family planning increase, but I had heard something about the women in government there, which had piqued my interest. But ultimately what motivated me was their family planning program success. Yeah.
I can take the questions.
Okay.
Try to answer in the next 2 minutes.
Okay.
I was just curious, did you see any indicators in terms of documents or variation in
Yeah, unfortunately, we don't know that. So we have the facility level, but we don't have like a provider. Oh, sorry. Differences in provider by providing desired method. We only have a facility level variable, not a provider level variable, which, you know, it's one of those lessons learned. I think we probably could have, and that would have been cool to include. But we do have facility level data, yeah. And we know which facilities are, we looked at the rates by facility. So we have that, but that's all we have. And interestingly, I was there with the students collecting these data, and I know which facility it is because I was entering the data, and it was the only place I was like, what the heck? What happened with this strange pile of papers? Yeah. It wasn't the only one, but it was a noticeable one.
Your research where you were looking at the cards for.
Yeah. Yeah.
What was your process in getting access to that data? Like, was there a conversation about patient privacy?
Yeah.
How might that be different than?
Yes. The question is about how the heck did I get access to these data? So the approval here was easy, and I think it's because it wasn't for patients here. But the approval in Rwanda was very difficult and very stressful because we actually didn't have approval. We arrived and we still didn't have approval. So I spent the first week we were there, like camped out in offices, doing my best. We eventually got it, and all we did was just keep talking about our plans and what we wanted to do. But yeah, they were really concerned about us having access to patient data, and it is in their documents. I can't remember which document, but there's a document that says like these data are confidential. But one thing we did is we didn't take any identifiers, and every Rwandan has a number, kind of like a social security number, but I'm not sure what they call it. But in hindsight, I actually wish we had taken it, because we could have matched records, because people go to different places, and so it would have been really interesting. But it felt insurmountable to ask for that, and because we barely got approval. But we do have the data now, and we're so eager, to share it back with Rwanda for them to continue to use it and things like that. So we've been very open and advocating for that to take place as much as possible. Yeah.
Thank you so much for your presentation. Over some food. So thank you all, and we'll see you next week.